thank the scientific and organizing committees for inviting me to speak today. I think it's a great initiative to build collaboration across specialties, especially for diseases that are multisystemic and require a strict multidisciplinary approach to help patients improve their well-being. My topic today is to give you an update on the treatments of inflammatory bowel disease. شغال يا لو سمحت. Okay. So the objectives of this talk, first of all, I'll start by a brief introduction, discuss some new mechanisms of action and drug targets in IBD, go over newly approved therapies for IBD, and then briefly discuss future IBD therapies. I'll start with a case that we typically see in our clinics. So this is a 28-year-old male with lower abdominal pain that awakens him from sleep, has intermittent diarrhea, describes lower back pain, and has a history of recurrent anal fissure. He visited the ER multiple times in the past 2 months and missed work on several occasions. On exam, he has a tender right lower quadrant, midline fissure, and perianal skin tag on inspection of the perianal region. His labs show mild anemia, low albumin, elevated CRP, and elevated fecal calprotectin, which is a stool inflammatory marker that we use to both diagnose and monitor patients with IBD. He actually only demonstrated minimal relief with the use of antispasmodics, which we typically use for symptomatic relief of IBS patients. However, as you know, there was a lot of red flags in his history and physical exam and lab, so we proceeded with an ileocolonoscopy that showed longitudinal serpiginous ulcers in the terminal ileum and cecum. MRE was done, which we always do at baseline for every patient diagnosed with IBD in clinic. Ileocolonic Crohn's with anterior enteric fistulas and multiple jejunal skip lesions were noted. So typical questions we'd have at baseline for patients with Crohn's disease is identify or label the patient's disease according to phenotype, and in this case it was a penetrating or fistulizing Crohn's disease. Assign patients a risk profile, given the patient's presentation, phenotype, and findings on labs and on cross-sectional imaging, we thought that this patient was among the high-risk group for complications. And in Crohn's disease, this is very important as we base our treatment on this risk profile assignment. Given this risk, we started him on combination treatment, which is infliximab plus azathioprine. I know this is a common regimen used in rheumatology as well. So we started on infliximab 5 milligram per kg. Our induction regimen is at week 0 to 6, then every 8 weeks for maintenance. And it's 5 milligram per kg as opposed to lower doses used in other diseases. He was also kept on azathioprine 2.5 milligram per day orally, which is the maximum therapeutic dose we use. So he achieved clinical remission at week 8. Fecal calprotectin actually normalized. Ileocolonoscopy was repeated 6 months later and showed significant improvement. But what usually happens in patients, or what happens in a significant proportion of patients happened with this patient, his symptoms occurred in a year and his fecal calprotectin shooted up to 1,000. We repeated the colonoscopy and there were severe ileal ulcerations. We tested him for infliximab anti-drug antibodies and it was positive, and his serum infliximab trough concentrations were adequate. So what happened and what should we do next? This is a common scenario we face in our daily clinical practice. So just to step back a little bit, I'll give you a brief introduction on what we do for our patients. So usually initial steps after diagnosis include we confirm the diagnosis, assign risk profile, educate patients obviously about the disease, counsel them about compliance, and make a large effort to recognize flares during follow-up. We usually outline the treatment plan to patients and explain the difference between induction, maintenance, and then followed by optimization of treatment and what happens if treatment fails. Our general goals of therapy vary. Historically, there was focus on only symptom control, but over the past decade, this has shifted towards more objective means of follow-up and more objective endpoints. Solid or very important endpoints such as steroid-free remission are sought after, and the most important probably endpoint that we look for is mucosal healing, which is healing of the mucosa of the colon and small bowel, which has been associated with favorable outcomes. Deep remission is a more stringent outcome. We don't aim for it, but if we see it, we're very pleased because it's also associated with a good outcome. And obviously, all of this is to prevent complications such as colectomy, bowel resection, and cancer, and to preserve patients' quality of life. Unfortunately, we face barriers in our daily practice, such as availability barriers, which is usually related to finance and accessibility. And in a certain percentage or proportion of patients, there is failure of therapy. I'll talk about that briefly in a few slides. Of course, things like primary non-response, secondary loss of response happen. There's also the issue of non-compliance, intolerance to drugs, and development of adverse events. The general approach historically was to target the immune system in a non-selective way, such as by using steroids and immunosuppressants, but unfortunately this leads to off-target side effects which we try to avoid. Of course, there used to be an approach to remove diseased parts of the bowel, but with time this has been proven to be both associated with morbidity and mortality, and we know now that this is non-curative for Crohn's disease especially. These are the treatment options for IBD in general: 5-ASA, steroids, immunosuppressants, anti-TNF agents, some unconventional approaches, and novel investigational drugs such as those in RCTs, and finally surgery. In ulcerative colitis, it's usually a step-up approach where we start with least effective, safe options, and with time go up the therapeutic pyramid as needed depending on the follow-up and monitoring findings. In Crohn's disease, like I mentioned, it's different. We usually base treatment on risk profile. If patients demonstrate high-risk features or alarming signs, there's many we follow and described in the literature. Then we go with top-down approach, starting with highly effective treatments early, usually TNF inhibitors and immunosuppressants. And as you can see, no matter which approach you choose, TNF antagonists are considered cornerstone of both approaches, and we rely on it highly, mainly because they're very effective and they were considered something very promising in the evolution of treatment of IBD. Unfortunately, well, let's just say that we have first lots of evidence that they work. These are landmark studies from different anti-TNF agents, but unfortunately there are some shortcomings to anti-TNF. The first one is primary non-response, which is, in our literature at least, can go up to 40%. There's also the phenomenon of secondary non-response. This is a meta-analysis that was recently published that pulled data from different RCTs and showed that this rate is about 33% with a median follow-up of 1 year, which is 1/3 of patients treated with anti-TNF agents. And this is attributed to the development of anti-drug antibodies, as we all know. The other shortcoming or disadvantage is serious infections associated with these agents. As you can see, the odds ratio for infection or serious infection is very high, especially when there's combination of drugs with anti-TNF agents. Finally, the association between anti-TNF agents and malignancies, specifically development of lymphoma. And again, this becomes higher once anti-TNF agents are combined with immunosuppressants. So what solutions do we have? Do we optimize the treatments that we currently have, such as using personalized medicines, updated treatment endpoints, or do we go with alternative approaches such as going from step up to top down, or combination treatment, which we know is also effective? Other options would be to go or shift our direction towards newer therapies such as cytokine inhibitors, signaling pathway inhibition, and the promising class of selective gut inhibitors, which I'll be talking about all individually. Of course, the cytokine profile between autoimmune diseases vary, but there's a lot of overlap, and we know that there's many drugs that work across autoimmune diseases, but there's also some differences. I know, for example, that etanercept is used a lot in rheumatology, but it has been proven to be ineffective for inflammatory bowel disease, and we never use it actually. So there's lots of differences, but nevertheless, there's a lot of mechanisms of actions that have been identified, and accordingly, many drugs have been developed targeting these different pathways. So we'll start with targeting cytokines, and the first pathway I'd like to talk about is the IL-17 pathway. Of course, everybody's familiar with the drug ustekinumab. I know it's being used a lot in rheumatology. It's a monoclonal antibody that works against the P4 subunit that is common between IL-12 and 23. It's approved for moderate to severe psoriasis, psoriatic arthritis, and recently for severe Crohn's disease. This is the Unity Phase 3 program for Crohn's disease. It's a large RCT that combined two cohorts, Unity 1 and 2. One is patients that have failed anti-TNF agents, and 2 is patients that only failed conventional treatment. Responders were then randomized to the drug or placebo in the maintenance phase, and following that, patients were recruited to the long-term extension part of the study. The primary endpoint of the study, which was clinical remission at week 6, was met. As you can see, the drug is effective, and that was demonstrated in both cohorts. At week 44 for the maintenance phase, again, the drug was effective for Crohn's disease, and since then it has been approved as a treatment option and is widely available in the market. What was important to note is that the drug was fairly safe when compared to placebo. There was not much, there was actually not any signal that indicated that we should be concerned about things like infection, for example. 3 weeks ago, this was presented at the ECHO meeting in Copenhagen, which is ustekinumab being studied for ulcerative colitis. And again, the drug was proven to be positively effective, and it's expected to be hopefully approved for ulcerative colitis as well within the next 6 months. Another cytokine inhibitor, which is interleukin-23, risankizumab, was again studied in Crohn's disease. This is a phase 2 study that was presented 2 years ago, and the drug was proven to be effective and moved forward to phase 3 studies, and we're expecting the results very soon. So moving to signaling, so the 3 drugs that I'd like to talk about in this pathway is number 1.
5 minutes left.
5 minutes. Is tofacitinib, which also you're familiar with, and it's a JAK kinase inhibitor. Second is the PDE4 inhibitor, which is apremilast, and then there's one drug that was actually proven to be ineffective, and I won't be talking about. So you're all familiar with tofacitinib. Many cytokines act on this pathway. The drug was investigated in ulcerative colitis. These are the OCTAVE studies, and the drug was found to be effective for both induction and maintenance, and this is different endpoints. The other JAK kinase inhibitor is filgotinib, and this was again studies in Crohn's disease, and it moved forward to phase 3, and we're also expecting results from this as well. I'm sure you're all familiar with this drug, upadacitinib, which is another selective JAK inhibitor, which was proven to be positively effective in rheumatoid arthritis, and recently AbbVie announced that they submitted an application for priority review, and I think this is going to be approved for RA as well. It was studied in both Crohn's and UC, and there was signal that this drug is positive, and it's moving forward in the drug development program. It was also assessed in UC, and we're expecting more results. So this is the pipeline for JAK inhibitors. I'm just moving forward to the PDE4 inhibitor, which is also showing promising results for UC. It has moved forward to phase 3, and we're expecting results. This is actually the category that I want to talk about the most, which is selective inhibition of gut inflammation. This is a pathway that is really of interest in drug development programs. We have drugs that act selectively in the gut and don't show any systemic inhibition. This is how the drug works. It's called vedolizumab or Entyvio. These are the studies in both UC and Crohn's disease. The drug was very effective across all endpoints and induction and in both anti-TNF naive and exposed. However, it was more effective when the patient did not receive any prior exposure to anti-TNF. I'm just going to scroll through these results. This is a meta-analysis that showed data from RCTs. This is very important. The drug actually has lower side effects compared to placebo. There is no systemic inhibition. And the reason this is important to rheumatologists, because you will see this more with time, patients who are on selective gut inhibition might develop more extraintestinal manifestations and mainly arthritis. There's more selective drugs down the pipeline. This is an anti-MAdCAM antibody, and this is another anti-beta-7, both now moving forward to phase 3 programs. The final drug is a different mechanism, which is called S1P1 receptor modulation, or ozanimod. Ozanimod is being used in MS, and there was evidence that it's actually effective in Crohn's disease. The large study Touchstone was published a couple of years ago and was proven to be effective. It's now moving forward to phase 3 and 4 programs. So the galaxy for drug development in both Crohn's disease and UC, as you can see, is very promising. There's more and more drugs being developed, and we're expecting the next 5 years to show lots and lots of release of drugs of different mechanisms of action. So take-home points: there's largely unmet need for effective medical therapies in IBD. Anti-TNF agents are effective therapies that are limited by consequences of systemic immune suppression as secondary loss of response, mainly due to immunogenicity. Gut-selective drugs that are associated with the lower risk of systemic infections are becoming more attractive options. Selective leukocyte adhesion molecule inhibitors, JAK kinase inhibitors, and anti-cytokines are new therapeutic classes for IBD that are showing significant promise and hopefully will be available in the near future. Thank you very much.
Thank you, Dr.